I'm looking forward to the next session that we're going to have on disease modifiable treatments. So Professor Suzanne Timmons is kindly offered to chair this session. So Professor Suzanne Timmons is senior lecturer in the Center for Gerontology and Rehabilitation, UCC, since 2010, and is the program coordinator for the MSc in Older Person Rehabilitation. So thanks very much, Suzanne, and I'll turn it over to you.
Lovely, thanks very much. I might actually just say in UCC, as well as the Masters in Older Person Rehabilitation, we have a Masters in Dementia as well. I feel I need to put that plug in while people are sitting back down again. So look, everyone, you're more than welcome to join us at this session. I'm going to start sharing my screen with you now, and you will see what we're going to be doing. So I'll get started. So I'm Suzanne Timmons, as you've heard, and I'm the clinical lead in the National Dementia Office. And my colleagues today are Dr. Seán O'Dowd from Tallaght University Hospital, who's a clinical neurologist, and he's co-director of the memory clinic there, and Professor Iracema Leroi, who's a psychiatrist of old age in St. James's Hospital and also in the Global Brain Health Institute in TCD. And we're going to talk about disease modification in dementia. And what we're going to do is we're going to present very briefly each. So I'm going to talk about reducing risk of dementia and slowing dementia progression in terms of lifestyle things we can do. And then Seán is going to talk about the concept of disease modifying treatments and what's coming down the tracks. And then Iracema is going to talk about a particular disease-modifying treatment that's currently under consideration. And our plan is between us, we're going to talk for about 20 minutes. So we're going to try to leave close to half an hour for questions from you. So I'll keep going here. So I'm going to talk, as I said, about simple measures to prevent or delay or slow dementia. And this is really important that it's part of our national dementia strategy, which was launched, as you know, in 2014, and which has 6 pillars. And 2 of those are about better awareness and understanding, and then timely diagnosis and early intervention. You know, it's not so long ago, what I used to hear from people was about the stigma and shame around dementia. So people saying things like, well, if I had dementia, I'd hide my symptoms from others. I'd be ashamed or embarrassed for people to think I had dementia. Or families would say, oh, don't tell the person they have dementia, it would kill them to get the diagnosis. And among health and social care professionals, we do a lot of what I call therapeutic nihilism, this feeling that actually there's nothing much we can do. So why would you diagnose a person with dementia? Because we can't do much. And there was a lot of poor understanding around dementia. And actually for a long time, people didn't really understand the different types of dementia. And people felt, sure, it's all dementia, sure, it's all the same. And it's really great to see that this is changing bit by bit. So first of all, in terms of the public, we've been running the Dementia Understand Together campaign since 2016. And this was to really support the public to understand dementia better, to reduce stigma, and more recently to empower communities to continue to be able to support a person with dementia so they could stay, you know, an active and valued member of their local community. And in the most recent survey, which is great to see, 91% of people believed that timely diagnosis was beneficial. But when we asked people, well, if you developed some symptoms that you were worried might be dementia, would you go and seek help straight away? 9% of people said, no, I'd try to hide my symptoms. So we still have a little bit more work to do, but I think things are improving. And then in terms of the National Audit of Dementia data, so this is the Irish National Audit of Dementia Care in Acute Hospitals, and it's charts from 900 people with dementia in all our acute hospitals across Ireland, and it's 2019 data. We looked and saw was the type of dementia diagnosed, and in only about 50% of the charts was the type of dementia documented. In the rest, it just wasn't clear. Now, of course, you might say, well, maybe it was documented somewhere else, or maybe people knew it and they didn't document it, but still it's a little bit concerning that not everyone has their type of dementia diagnosed. And as you'll hear, that's becoming more than ever important. So why should people seek help and seek diagnosis early? So I suppose if you're worried about your cognition, and that can be your memory for a lot of people, but it might be problems with language, with understanding what's being said, with thinking of a word, with navigating your way around, with understanding how things work. So it doesn't always have to be memory. So if you're worried about your cognition, it might be that you have a thing called subjective cognitive impairment. And I suppose, to put it very simply, that's where, maybe you're worried about your cognition or memory, but tests and further assessments say, no, at the moment, there's nothing definite wrong with you, if I could put it that way. And the really important thing is, before we used to just reassure people, and now we realize that we're missing a great opportunity to reduce risk factors, because anyone who's worried about their memory maybe is at slightly higher risk in the future of going on to develop dementia, but it's often, it's also that a person's really motivated to change their lifestyle. And then for some people, they're diagnosed with a thing called mild cognitive impairment. And this means that there is problems with how their brain is working, but it's not yet at a stage where it's affecting their function. And again, here, it's really important that we reduce any risk factors for dementia, and we can offer people cognitive therapy. And I think a lot of people don't know this, that there is things we can do for mild cognitive impairment. And then for a person who is diagnosed with dementia, both of these remain really important, but we often, for a lot of types of dementia, are also offering medications. And of course, now we have the added thing of disease-modifying treatments, and you'll be hearing about these now in a minute. So I suppose, to summarize it, for everyone, we want to assess risk factors for dementia, we want to offer therapy, and we want to give medications. And as well as that, we want to give people information, emotional support, and practical support. So I wanted to also say, what can healthy middle-aged and older people do to reduce their risk of dementia? And I suppose at the start of it, we have to think, as a society, what do we need to do? We need to reduce societal inequities. We need to make sure all children are educated. We need to avoid air pollution. And we also need to be avoiding head injuries, and that's people at any age of their life. And that's something certainly sporting bodies need to think a little bit more about. But for an individual person, one of the most important things is to keep your brain healthy. And we talk about brain reserve. That's basically structurally how healthy is your brain. And what we need is healthy blood vessels going to your brain. So the WHO really recommends physical activity to keep your brain healthy and to not smoke. And then there's mounting evidence for things like following a Mediterranean diet, managing diabetes and hypertension, not drinking to excess, and for middle-aged people, keeping an eye on, obesity and your lipids. Probably not so important as you get older, but important in middle-aged people. So all of these are really useful things that keep your blood vessels healthy, and not just the blood vessels in your brain, the blood vessels all over your body. So they'll also reduce the risk of stroke and heart attack. So these are really win-win things. But there's also things that are really important just for dementia. So not just keeping your brain structurally healthy, but keeping it working well. And we talk about cognitive reserve. And things that can help this is cognitive training. So exercising your brain, doing crosswords, doing Sudoku, learning a new instrument, learning a new language, keeping your brain exercised. Hearing loss is another risk factor that's probably under-recognized. So if you have mild hearing loss, you're twice as likely to develop dementia. And if you have severe hearing loss, you're 5 times as likely. So all of us throughout our lives need to be protecting our hearing. When you get to middle age, if you're worried about your hearing, you should have it checked out. And if you're prescribed a hearing aid, to wear it. And then the other really important thing to reduce risk of dementia is social interaction. So lifelong learning, keeping yourself cognitively active, keeping yourself out and a member of the community. When somebody might have mild cognitive impairment or possible dementia, there's a lot we can do for the person. So we can refer them to their local memory assessment support service for brain health support. So sometimes people struggle with lifestyle factors and they need a little bit of help. Cognitive stimulation and cognitive rehabilitation. Access to memory technology resource rooms. So these are run by occupational therapists, and they'll do a really holistic assessment of a person and support the person to continue to live their life, adapting to any problems that they do have, and where necessary, giving technology as support. We consider people for medications and other medical interventions, and of course, information and support. So there's an awful lot we can do for a person, but none of that happens if somebody doesn't seek help or they're not facilitated to get help. So look, if anyone wants any more information, our Dementia Pathways website is our website for health and social care professionals. We've lots of resources all about dementia, but we've resources on brain health, We have a service finder for local services in each county. So you might be looking up for yourself, for a family member, or for a client. Details of the memory technology resource rooms. And at any time you can contact the National Dementia Office or myself if you want any more information on anything that I've covered now. And I'm going to hand you over to Dr. Seán O'Dowd, Consultant Neurologist in Tallaght. He's going to talk to us next about disease-modifying therapies in general.
Thanks, Suzanne, and thanks for inviting me to speak today on this topic. So as Suzanne has said, I suppose there are, modifiable approaches which are non-pharmacological, but the next part of the talk is looking at disease-modifying therapies from a drug and pharmacological perspective for dementia. What does disease modification mean, or what do we mean when we say DMTs or disease-modifying treatments? So these are drugs that slow or halt the progression of a disease process. And they do this by targeting the underlying pathological processes that are driving the disease. So in this respect, they differ from what we call symptomatic treatments, which are targeted at a downstream effect of the disease process. So many of you will be very familiar with some of the symptomatic treatments which are currently in use for different types of dementia, particularly Alzheimer's dementia and the Lewy body dementia. So the prime example being the cholinesterase inhibitors, donepezil, or Iracema, as the original brand name was, rivastigmine, which was Exelon, and galantamine, which is Reminil. And these drugs are cholinergic stimulants, which sort of enhance attention span and memory pathways driven by acetylcholine in the brain. And in so doing, they can treat some of the symptoms experienced from a cognitive and to a certain extent a non-cognitive perspective by patients with dementia, but they don't alter the underlying disease process. Memantine, as you know, is another symptomatic treatment, works in a different way, but again, it doesn't have a disease-modifying effect. So these are drugs which work on the manifestations of the underlying disease process, but don't alter it. So when we talk about altering or targeting the disease process, well, what are the targets? Well, this will depend on the disease. And referring back to what Suzanne alluded to at the start of her talk, the importance of trying to get as close and accurate a diagnosis as we can in terms of the subtype of dementia that somebody is presenting with. So the vast majority of dementias can be considered proteinopathies. So what do we mean by this? Well, essentially normal proteins which are present in the central nervous system in several neurodegenerative diseases begin to fold and aggregate and clump and accumulate abnormally. And this leads to dysfunction in the nerve cell and ultimately in cell death. And in each of the dementias, and I'll come on to this, there are particular proteins which are associated with the disease process specific to that disease. Now, it's probably not quite as simple as just the protein misbehaving, but certainly it's felt that the protein aggregation is one of the key drivers of the disease, but other things can influence or accelerate that. And for example, we know that vascular disease can certainly accelerate and exacerbate most of the neurodegenerative diseases, as can other factors such as inflammatory processes, metabolic factors, and loss of synaptic plasticity in the neurons. And each of these can potentially, in their own right, be adjunct pathways or targets that could be used in designing a disease-modifying treatment. So, as I said, each of the neurodegenerative diseases has a particular signature in the sense of the protein which is behaving abnormally and is found to accumulate when we look at the tissue of patients who have undergone, say, for example, an autopsy after they've passed away, to see, well, what exactly was the driving force for their disease. So decades of research have shown that in Alzheimer's disease, the disease is associated with abnormal accumulation of two proteins, beta amyloid and tau protein. In the Lewy body dementia, so that's dementia with Lewy bodies, and Parkinson's disease dementia, the protein which is accumulating is a different protein. It's called alpha-synuclein, and that can accumulate and form particular pathological sort of little findings that can be seen under the microscope called Lewy bodies, and hence the name Lewy body dementias. In frontotemporal dementia, again, there are two different proteins which can cause the disease. Now, they don't occur together. Alzheimer's is kind of unique in that regard, in that there's pathology from two proteins, beta amyloid and tau. In frontotemporal dementia, it's either tau or another protein called TDP-43. And sometimes clinically, we can, to a certain extent, based on the particular presenting syndrome of frontotemporal dementia, go some way towards perhaps predicting which of those proteins is the driving force for a patient's FTD or frontotemporal syndrome. There's another sort of version of frontotemporal dementia, which is associated with motor neuron disease called FTD-ALS. And again, in this, we see that either TDP-43 or tau is accumulating abnormally in the brain. And in a certain number of familial cases is another protein involved, which is called FUS protein. And then there are what we call the atypical Parkinsonian syndromes, most of which are associated with cognitive symptoms or dementia as they advance. And these are progressive supranuclear palsy and corticobasal degeneration. And these are exclusively caused by tau accumulation. So as you can see, when we identify the particular sort of clinical syndrome, there's a huge value in that from a drug treatment perspective, particularly for the future and for future treatments, because then we would have a much clearer idea of what protein is behaving abnormally and therefore what would be the target for a drug treatment. So what's the pipeline like in terms of disease modifying treatments? So there was a very useful presentation at one of the big dementia meetings in the spring, ADPD, where there was a review of where things stand in terms of the drug pipeline for dementia. And at present, there are 121 molecules undergoing trials for Alzheimer's disease and other dementias. Interestingly, 40% of these are drugs which have been repurposed. So in other words, medicines that have originally been designed or licensed for other indications and other conditions, but where there is a hope or an expectation that they may in some way have a disease modifying effect on neurodegenerative diseases. And a couple of examples of this would be some of the medicines which have been used for diabetes in recent years. So of the 121 medicines in trials, 97 of these were disease or potential disease modifying treatments, and the others were targeted at symptoms. And 29 drugs were in phase 3 trials, which is the sort of more tangible trial with patient involvement, looking for clear evidence of safety and efficacy. So what were the drug targets? Well, 16 of these were targeted at amyloid protein, 11 were targeted at tau protein, 20 were targeted at inflammation, which is felt to be a sort of a driver of the protein aggregation in neurodegenerative diseases. 20 were targeted at synaptic plasticity, and 9 were targeted at metabolic pathways. And again, an example of this would be some of the insulin and the insulin resistance pathways have been implicated in some of the neurodegenerative diseases, such as Alzheimer's disease and Parkinson's disease. So what are the challenges with these potential new drugs? Well, one of the most significant challenges, I think, is logistical, which is that several of the most promising compounds, and Ira is going to speak about one which has been licensed in the US recently, are what we call biologic drugs. So these are monoclonal antibodies, and these are delivered by intravenous infusion, usually very frequent intravenous infusion, and that, of course, is quite burdensome for the patient and also has resource implications for health services. Another challenge, I suppose, would be no more than what we would see in other neurological conditions, such as, for example, multiple sclerosis. The earlier you identify a patient with a disease process, the more likely they are to benefit from the introduction of a disease-modifying treatment. And therefore, we're talking about trying to capture people very early on in the disease process with dementia, even perhaps before they have any clinical symptoms at all. But that's a somewhat tricky and fraught issue, because there are lots of cognitively normal people from middle age onwards who may have some of what we call the biomarkers of Alzheimer's disease, but who don't have symptoms and who may never develop symptoms or develop the disease clinically. So that's a challenge. And then, of course, like any medicine, and particularly intravenous drugs, I suppose, there is the burden of potential side effects and the surveillance for those side effects, such as frequent scanning and laboratory testing and so on. And lastly, I suppose, the question of, well, how do we define a response to these drugs? So that's my piece done, I think, and I will stop sharing and hand you back to Suzanne.
Fantastic. Thanks very much, Seán. So I'm delighted to introduce Iracema Leroi. So she's a professor in Trinity College Dublin and the Global Brain Health Institute, and she's psychiatrist of old age. And Iracema runs a very specialised movement and memory clinic, and she's going to talk to us about one particular drug of those disease-modifying treatments that is already licensed in America and is being considered for use in Europe. So Iracema, I'll hand it away to you there.
Thank you very much, Suzanne, and it's wonderful to be here. So I'm going to talk about aducanumab, but I'm going to put this in the context of what's really quite a political story. So whereas, of course, science and clinical medicine is driving this and has led to this drug now being licensed by the Food and Drug Administration in June of 2021, there's a whole other aspect to this, which is quite interesting and important for everyone to be aware of. So you've already heard from Seán that we have a number of drugs available for treatment of people with Alzheimer's disease and other neurodegenerative disorders. And the last ones that specifically focus on cognitive impairment for the symptomatic treatment have been last licensed in 2003. So it's been a very long time since we've had anything new. Having said that, it is important to be aware that for the neuropsychiatric symptoms, in other words, additional presentations like insomnia and psychosis, there have been some drugs licensed. But here we're specifically talking about disease modification, in other words, slowing of neuronal death, rather than treating just the symptoms. The drug is called aducanumab, or Aduhelm, which is the brand name. And the pharmaceutical company behind it is Biogen. And this has been huge news in America, as you can imagine, because this is the first disease-modifying drug that's been licensed for this indication, in other words, Alzheimer's disease, ever. It hasn't really hit the news here in Ireland or even in other parts of Europe. And that's because, of course, we don't yet have that licensed here by the European Medicines Agency. But it's being looked at very closely, and whether it will get a European license or not will depend on a number of things. So I'm going to take you through this story. So first of all, even though this seems to be a new story, it's not. We've been looking at disease-modifying drugs for over 20 years. It can take a decade or more for a new molecule to get to the point where it reaches a clinical trial, and we can determine whether it's licensable or not based on whether it's effective or not in clinical trials. So it's a very, very long process. And up until very recently, up until now, essentially we could say that nearly 100% of randomized controlled trials, RCTs, for Alzheimer's disease failed after we had the initial license of the symptomatic therapies in 2003. And back in 2018, when one of the most promising trials failed, one of the most promising drugs called solanezumab failed, everyone was feeling very demoralized and nihilistic. Again, the term that Suzanne already brought up in another context. In other words, would we ever find the disease-modifying therapy for Alzheimer's disease? But since that time, there's now been renewed energy into the field, and the licensing of this new drug, aducanumab, has been extremely important. So this brings us into what we can call the post-donepezil era. Now, donepezil is the most commonly prescribed drug for Alzheimer's disease, which Seán mentioned, and treats only the symptoms. But we're in a completely new phase because we're moving beyond just treating symptoms, and we're trying to slow down the cell death that's underlying and driving this condition. So here you can see the drug, Aduhelm, over there. It's a little vial because it's not taken orally. It's taken by IV infusion on a monthly basis. And what it does is that it attacks the abnormal proteins that build up, at least one type of abnormal protein, or it's actually a conglomeration of proteins that build up and are characteristic of Alzheimer's disease. So we're not saying it causes Alzheimer's disease, we're saying it's characteristic of, and that's an important point, because it doesn't necessarily mean that if we attack these clumps of abnormal protein called plaques, we will necessarily get all the results we want. And you can see here a picture of an amyloid plaque here. And so when this attack happens by the drug binding to it, you get stimulation of microglia to clear them away and try to restore some health back in the neurons or the brain cells. And microglia are essentially cells that are like the vacuum cleaners in the brain. And the more they're stimulated, the more restoration we can get. Now, the FDA, the Food and Drug Administration, did not give an absolutely clean bill of approval to this new drug. It put it on an accelerated approval pathway. And what that means is that the company Biogen has to conduct additional clinical trials, what are called phase 4 trials, to verify that this drug actually has a clinical benefit. And I'll come to what that means in a moment. In other words, there are some indications that the drug may clear these plaques and restore some degree of normality in the brain tissue. But then there's the so what question. In other words, does it really make a difference to the clinical presentation of the patient? Does it slow their course? Does it improve their cognition, their function, their quality of life, and all these other outcomes? And that is something that we don't quite know yet. Usually, you need to have demonstrated that kind of effectiveness or efficacy in order to get a drug licensed. In this case, accelerated approval pathway, you don't have to demonstrate that. You simply have to show that there's some kind of plausible biological basis for the drug working. In other words, what's called a surrogate endpoint. And in this case, the surrogate endpoint is looking at the amyloid load. How much of this gunked up abnormal protein is still in the brain? And if it's less, then they're saying that the drug shows some degree of effectiveness. Now, coming back to this condition that's put on the pharmaceutical company, is that if the trials, these phase 4 trials, fail, the license will be revoked. So here in Europe, what we don't know is whether the European Medicines Agency will approve the drug in a similar way, or they will say, no, wait, let's see what the American trials show and whether the FDA will give full approval to the drug after the trials have demonstrated clinical effectiveness, or whether it will be revoked. So that's kind of the holding pattern we're in now here. What was also very interesting and political about the approval of this drug is that it was indicated for the treatment of Alzheimer's disease. Now that sounds very straightforward, but it's not at all, because of course Alzheimer's disease is a huge spectrum, all the way from people with prodromal Alzheimer's disease before they reach the dementia stage, all the way to the point where they might have advanced Alzheimer's disease with significant dementia and everything in between. And so when this approval came out, this broad indication was listed. And for the clinical community, of course, this has caused quite a bit of unease, because there's very few people on the clinical side who will suggest that we use a drug like this for somebody with very advanced Alzheimer's disease, for whom it is very unlikely to benefit. Because of course, once you've got significant damage in the brain, the chances are that a drug like this will make a difference are very small. And more importantly, we don't have evidence to support that. So what did the studies show and who were they for? And this is important because this is what the clinical community is now pushing for, that if we get a license here in Europe, that we use this drug only for the same kind of people, the same indications that the clinical trials had. So there were two studies. One was called Engage and one was called Emerge. And those are simply the names of the trials, very, very similar. And they included each over 1,600 participants all around the world. And these were people aged between 50 and 85. So the first point, if we have somebody who's 90 who presents with Alzheimer's disease, we likely will not consider them for this treatment because we don't have evidence for people in that age group. Also, the people in these trials had what's called mild cognitive impairment, or MCI, due to Alzheimer's disease. In other words, they had Alzheimer's disease in their brain prior to a full dementia syndrome, or very, very mild stage dementia because of Alzheimer's. So no other kind of dementia or no other kind of neurodegenerative disease. It had to be Alzheimer's, either in the extremely early stage of dementia or in the prodromal pre-dementia stage. So again, this suggests that if somebody is 90 years old with very advanced stage dementia due to Alzheimer's, they would not be eligible for this drug because it likely would not be appropriate for them and would likely not be effective. The other important point is that people were not included in these trials if they had significant other pathology in their brain, like stroke or vascular changes. And why that's important is because many people who present with Alzheimer's disease type dementia also have other kinds of pathology in their brain, like, for example, stroke-related changes. And if there's a high load of that, we'd have to be very careful and think twice about using this drug. And of course, everybody in the trial was very healthy. Now, I'll just move fairly quickly through this. Again, the important point to remember, and again, why there's been a lot of discussion and some controversy about this licensing, is because of the two trials, even though they were identical, only one of them met what's called the primary endpoint. Only one of them was entirely what we call effective, based on the clinical outcomes called the Clinical Dementia Rating Scale. The other trial did not meet effectiveness based on this clinical rating scale. In other words, it did not show improvement across a range of different domains, such as cognition and function. It only showed change in the underlying biology. In other words, reduced level of amyloid plaques. And we could determine that based on brain scans, as well as looking at the level of the abnormal protein in CSF or cerebrospinal fluid, which is taken through a lumbar puncture. In other words, surrogate biomarkers. So I'll just very briefly tell people what the CDR is, the Clinical Dementia Rating Scale. So as you can see here, if you look down here across the first column, this is a kind of composite scale which judges how a person is doing in terms of memory, orientation, judgment, problem solving, managing the community affairs, how they manage life at home and their hobbies, and their personal care. So it's a kind of almost a 360-degree rating scale of how a person functions. And in the one trial, this composite scale showed improvement on the drug, but in the other, it didn't, even though the biology changed. How will this drug be used? I've already mentioned, by monthly IV infusions. So this, of course, has implications for how we deliver it, because for those of you who are familiar with memory services right now, we don't have these kinds of setups. We do in other parts of the medical system and other services within neurology, like for multiple sclerosis, but not within the memory services. Our drugs are pretty simple and are given as small oral tablets. The other point, of course, is that we would have to look at the risk of side effects very carefully. And the main side effects that we're concerned about are particular changes in the brain called ARIAs. ARIAs are what we call amyloid-related imaging abnormalities, which are small bits of swelling and bleeds in the brain that may be caused by the drug resorbing or pulling out these plaques. Most of the time, it's not a problem. However, some of the time it can be a problem, and therefore we need to monitor them. How will that monitoring be done? That will be done using brain scans or MRIs. Again, another resource implication. Usually we use MRIs for the diagnosis only, but now we might have to use multiple MRIs to monitor whether people are developing these side effects. Finally, I'll just point out here, this is called the Appropriate Use Recommendations paper, which has not come from the FDA. This has come from clinicians in the field who are used to working with these kinds of drugs. And they're suggesting how we should be using them in a clinical setting, which is quite different from what is being suggested by the FDA. And these are the kinds of guidelines that if we get the license here in Ireland, we will be following, and they will follow quite closely the kind of structure and indications from the clinical trials themselves. So finally, how are we looking at this? We have what's called the Irish Disease Modifying Treatment Group, the DMT working group, in which we're trying to figure out all these things so that if and when we get a license for this drug here in Ireland, we will be ready and we will know how are we going to use the drug, how it will be paid for, exactly what the indications will be, how we will monitor it, and where we will monitor it. Do we have enough scanners in the country to be able to do this kind of monitoring? What will be the cost benefit? Will we do this treatment in one single place, or will we do it across the country in different places? Do we want advocacy led by the pharmaceutical companies, or should we take control of it? So these are just some of the many, many questions that we need to consider, because this is a whole new landscape in this post-Donepezil era. So I'm going to end there. Thank you very much.
Fantastic. So thanks very much, Ira, and thanks, Seán. And I hope we've given you a flavour of some of the really exciting things that are happening around dementia at the moment. So I've been keeping an eye on the questions, and I'm going to start with some of the ones that are in already, and it'll give the rest of time to put in some more. So one of the first questions that came in was about menopause and brain fog. You know, we've all heard of this, that women develop brain fog around the time of menopause. And is that a risk factor for getting dementia later? So I don't know if Seán or Ira want to say something. If not, I can jump in myself.
Well, I mean, I suppose what we do know is that women are at higher risk, you know, of developing Alzheimer's, certainly, than men. And that's the reasons for that aren't fully understood. I mean, there is some theorizing that it may be due to estrogen deficiency post-menopause. But I suppose the data around replacing estrogen with HRT is very contentious, and certainly there is no compelling signal that any potential protective benefit of HRT from a cognitive or a neurodegenerative perspective would outweigh the potential risks, which everyone will be familiar with longer term use of HRT. So as it stands, you know, I suppose it's not something that there's a very clear indication that HRT would have a neuroprotective effect. But it is something, I suppose, which is still a subject of some debate. I mean, brain fog, I suppose, as a general concept, is a very diffuse sort of experience. And, you know, I suppose people will experience this type of symptom in lots of different contexts. I guess the key message I would say, you know, is that somebody particularly, you know, in middle age, you know, experiencing what they perceive as brain fog and some subjective change in their cognitive processing or their attention span or their memory should seek to have a medical input to look at that, because as you said, Suzanne, we know that people, particularly over the age of 50 or so, who have subjective or indeed may be found to have objective cognitive complaints are at higher risk over time of developing a definite cognitive syndrome or dementia.
Yeah, and actually I'm not going to come to you in this area because we have other questions to get to, and I think that's been a really clear answer there, Seán. And I would definitely add to that point of seeking attention and looking at your lifestyle, because this is a great opportunity to look at your lifestyle risk factors and make some changes. But you know, the majority of people, we'll say at the age of 50, which is typical for menopause, who are worried about their memory or other cognitive function, for the majority of people it will not be dementia. You know, that's the good news. It usually is menopause, anxiety, other events going on in your life. But definitely, you know, do seek help, see your GP, and use it as an opportunity to say, well, what are my risk factors, and is now a time to kickstart them. Now, unless you really wanted to jump in here, I was going to go to the next question because we have a few to get through. Fantastic. So another question that came up is in relation to the medications like donepezil and memantine that we were talking about. When should you stop them? And in fact, I think there's two questions that came in that are really linked. One is, when should you stop them thinking about advanced disease? And the other is, does donepezil only work for a while? Someone said they read that you only get benefit for around a year. So we might take both of those separately. One is, do they stop working after a year? And the other is, when should we think for somebody with very advanced dementia that we might stop them? So Ira, I might let you kick off with those.
Sure. So first of all, there's the evidence that these medications can be effective longer than a year, and that depends on so many different factors. It depends on the individual, it depends on their underlying diagnosis and what their brain looks like, because some people are on these medications who don't have the type of dementia or disease that even responds to these medications. So again, there's that to keep in mind. Also depends at the point at which they start these medications. If you start somebody with moderate stage Alzheimer's disease on these medications, their benefit will be shorter than somebody who starts at an earlier stage in the dementia course. So I don't think we can generalize. That's point number one. Point number two, about stopping. A number of years ago in the UK, we had guidance from NICE, the National Institute for Clinical Excellence, suggesting that we should stop at a certain point because these drugs were no longer effective. And that was based purely on what the clinical trial evidence showed. Since that time, there has been subsequent trial evidence of use of these drugs in people with more advanced stage Alzheimer's disease, and that the drugs have been shown to be effective. Now, what do we mean by effective? Does that mean that it's slowing progression? No. Does it mean that cognition is perhaps a little bit better? Likely. Or functional ability is a little bit better or slower than it would be if the person weren't on the drug? That seems to be the case. There may also be some protection against what we call the neuropsychiatric symptoms, like, for example, developing hallucinations, agitation, and so on. So it's a slightly complex answer because it's not that clear cut as to how is it effective. It is how we define efficacy. Now, related to that, I think the question says some people are on advanced disease and there's a hesitancy to stop. First of all, these drugs are safe. There isn't a huge pressure to stop them. But if one decides to stop because you're moving into more of a palliative stage or the person is having difficulty swallowing the drugs, then you need to think about slowly titrating and cutting back on the medication because you might have a sudden rebound and you'll see the person, what we call, fall off the cliff. In other words, deteriorate quite rapidly, which in fact is a bit of an indication that they were getting some benefit from it. So I think the real answer is it's absolutely depending on the individual, and it's a debate that has to be had with the family and, if possible, the person in question to decide whether they continue or stop and how you should stop.
Fantastic, Ira. And Seán, do you want to add anything to that?
No, I mean, I'd echo all of what Ira has said there. I think it's very individualized. I suppose the one other thing that sometimes comes up is if somebody has been started on a cholinesterase inhibitor and has clearly not yielded any benefit, in those initial few months, whether there's any value in trialing a different one. And I suppose there is some data to suggest that there is. So in my practice, I'll always switch class. I mean, there are little nuances about the mechanisms of action of each of the cholinesterase inhibitors, and there can be idiosyncratic responses. So I suppose that is something which in practice, I think a lot of us would do. But in terms of a decision around stopping, I think it is very nuanced. And as Ira says, there can be benefits that are somewhat unseen or beyond just pure the cognitive component in terms of the other kind of non-cognitive and neuropsychiatric symptoms that the cholinesterase inhibitors can help with. So withdrawing, it can be something, I think it's a judgment call at an individual level, and as Ira says, should be done slowly but surely if it's a decision that's been made on the basis of, just the burden of pharmacotherapy being not worth it anymore and somebody being maybe towards the palliative phase of their disease.
Yeah, and I'd echo that as well. I mean, there are people where they have very advanced disease, swallowing medications is an issue. And, for all medications that somebody's on, we look and say, is this helping a person's symptoms today or not? We're not worried about the future anymore, but we do have to be cautious that sometimes when we reduce medications, there can be withdrawal for sure. So I think exactly as we're all saying, slow, cautious, very individualized, but, I see such a change in approach where before it was really, if you needed residential care, what was the point of continuing, to now where we're saying people can get benefit into very advanced disease and be cautious, so it is that cautious approach, I think. So another question that had come up was about hearing loss. How can hearing loss increase your risk of dementia? So again, Ira, you probably have quite a few insights, and I can pop in as well if needed.
So I'll say a few things. Well, first of all, I think there are multiple mechanisms. We don't entirely understand it. What we know is their association. Is it causative? That isn't entirely clear. And also, if you fix your hearing loss with a hearing aid, for example, does that decrease your risk? There's some evidence to support that based on what we call epidemiological samples. But again, we need a lot more evidence. In other words, a prospective randomized controlled trial where you've got one group with mild cognitive impairment and hearing loss who get correction and the other group who doesn't, and you follow them into the future. Now, that's a difficult trial to do. There are a couple of trials like that ongoing, and we're still waiting for the results. But of course, there's all kinds of complexities, particularly the ethical issues of if you've got somebody with hearing loss and they're not getting hearing correction. So in terms of the kinds of links that one might look at, one very popular hypothesis is called effortful listening or cognitive load. In other words, if you've got hearing impairment, you often have to use a lot of cognitive effort to try to understand what a person is saying, and therefore you redirect, if you will, your energy, your cognitive energy from trying to remember, and therefore you may have difficulties subsequently with what appears to be a short-term memory problem. So that's kind of a mechanistic approach, which isn't the entire story by any means. But those of you who have some hearing loss, you may recognize that it can be very fatiguing if you're trying to understand what people are saying, and you can get cognitively very tired. The more likely explanation is that there's shared pathology. In other words, you've got a gremlin in the system that is pushing degeneration across these different systems, like, for example, in your hearing pathways and also within your cognitive pathways. And the pathology is building up in tangent. And of course, that's very much pushed by the aging process. So these are the types of pathologies that link in and cause the decline. So there's still a lot we don't know, but the evidence is clear there's a very strong link. The other thing I'm just going to say is, Suzanne talked very much about the risks and picking up hearing loss in middle age and so on. But another very important aspect is to think about hearing loss in people who have already developed dementia. And this is important because the majority, in other words, more than 80% of people who have dementia have not had their hearing checked and likely have a hearing impairment. And it can be quite difficult for them to learn to use a hearing aid, and they need a lot of support. However, that likely will make a big difference in terms of their quality of life and being able to manage with cognitive impairment. So that's something to think about as well. So I'll just leave it there.
Fantastic. And I'm going to add two things to that. The first is it's also possible as part of how hearing loss causes dementia that when you're not hearing, you're not taking part in conversations, you're not socially engaged, and therefore you're losing that. Remember I said that exercising your brain, and I don't think that's the whole story, but I think it probably is part of the story that you're not hearing that it's your granddaughter's birthday next week, so you're not having to remember to go out and buy the card and all of those things that normally keep our brains exercised. And could I say, I was skeptical at the start about the link between hearing loss and dementia, thinking, was it just a link? You know, that they were both common and things, but actually some of the studies I've read have very long follow-up with people, and these are healthy 50-year-olds with no hint of memory trouble who are going on to develop it. So I'm starting more and more to think it is a causation, but I totally agree with you. We need more studies, but ethically, I think we may never get those studies because how could we do it? How could we not give someone a hearing aid when we know they need it? But look, the message to everyone is protect your hearing, and for your children, protect your children's hearing. And if anyone's worried about their hearing, go and get it checked out, you know, is really important. So I see that Kim has come on board again. I'm guessing that's to tell us that we probably run out of time to give people.
No, we're actually right on the dot, but it's a good time, I think, to thank you for a lot of really valuable information, and for, as a non-medical person, I understood it. So that's the biggest compliment of all.
Fantastic. Thanks, and thanks for the questions to everybody. They really made it. Yeah,
exactly. So thanks very much for coming along.